All right, Ariana, welcome to the podcast. How are you?
I'm doing well. Super excited to be here. Thanks for having me.
Yeah, you bet. So tell us, I know a little bit more about you, but I'm going to pretend like I don't. I know that you are a Psych PA, which is awesome, and you're active on Instagram, which is also awesome. So tell us a little bit about yourself.
Yeah, so I am, well, I guess there's kind of a lot to the story, but I am a retired Psych PA. So I was practicing in psychiatry for almost 2 years, graduated in 2019, went straight into psychiatry, and we can get more into that. Have a huge passion for advocacy, mentoring, educating the future generation of medicine. So that's kind of why I started my Instagram page. I do a lot of mentoring on there, a lot of mental health awareness, stuff like that. I worked in psychiatry, and then I will be transitioning into a new role next month into Burn and Reconstructive Plastic Surgery.
Wow.
And there's also going to be an emphasis in burn critical care. So very excited about that.
I hear a future day in the life of that specialty in about 2 months. So if you start next month, then we'll have to circle back with you in 2 months and we can do another day in the life episode.
Yeah, absolutely. I'm all for it.
Awesome. Good.
That'd be great.
So what is it? I don't know much about psych other than I had a 2-week rotation in school. What's a day in the life like for a PA in psych?
Yes, I love this question. I think a lot of people don't want to know what a day in the life of a psych PA is. So I'm glad you asked. And there's so much variety. So every single day in the life of a psychiatry PA is going to look different. So I think most people assume PAs work in an outpatient setting. So it's medication, 15-minute appointments, in, out, goodbye. I worked in a completely different setting. I worked on kind of an intermediate setting. So I wasn't exactly inpatient and I wasn't outpatient. I was right in the middle. I did work in a hospital setting. So I was on an acute crisis stabilization unit.
Oh, wow.
So patients came to me kind of when they were in the thick of it. So some had either had a recent suicide attempt, that day. Perhaps they were, experiencing some type of crises. Maybe they were having stress that day, anxiety, depression, substance abuse, withdrawal. Anything was fair game walking through the doors. We primarily accepted patients from local emergency departments, but we also accepted patients from the crisis line or walk-ins. So it was a nice variety of patients, also with various acuity levels. So that's what I did. I also worked the night shift, and I feel like we all can kind of agree when night rolls around, everything is also a little bit more chaotic.
Yeah, for sure.
So I was primarily managing psychiatric conditions, but also a lot of medical conditions as well. My role came with a lot more autonomy. I was one of 2 providers in the entire hospital at night. So I was the only PA, and there was a resident present.
Wow.
Resident present.
Sure.
The resident covered the inpatient floors, and I covered my unit. And if there was a code happening, we would essentially both be required to be there and initiate the code.
Wow.
So anything medical was also fair game. Dealt with arrests, overdoses, things like that.
So not just psych issues. That was like the whole hospital.
Yes.
Oh my goodness.
So it was a little overwhelming stepping into that role as a new grad. I also didn't have nurses on my unit. I was pretty much the only medical professional on my unit, which could be very daunting as a new grad. So basically stepped into the fire and had to learn very quickly.
Yeah.
And that's just kind of something I emphasize to new grads is having a collaborative and supportive environment is very, very important. It doesn't matter how much money it doesn't matter how awesome your benefits are. If you don't have that collaborative environment where you can bounce ideas off of one another, it's not worth it.
Yeah.
I'm very thankful for everything I was able to learn. And I feel like that role really shaped me into the provider I am today. But that was difficult. I hated my life for a while. I'm not going to lie.
You're like, why did I get into this? This is crazy.
Yes, between learning how to become a vampire and then also learning how to, be a medical provider from being a student, it was a lot.
Yeah.
So
that's so much to balance too, especially as a new grad.
Yeah, it was. And then the pandemic started too.
Yeah.
Right.
About, a couple months in. I'm like, what is happening?
Yeah. This may be a question you get, and we'll get into more, about what you do. But speaking of the pandemic, is that something, we talk about in general terms that we see a lot of people with more depression, anxiety, just from the pandemic itself. Is that something that you being in that field in the past year have noticed that, oh yeah, for sure? Or is that just more of a stigma, I guess, that goes with, well, people are locked up, so we assume everyone's depressed and sad?
I think everyone has an underlying amount of some type of mental health condition, whether it is known
For sure.
or they haven't
unknown.
realized it yet. But I think, the first wave of the pandemic was those medical conditions coming forward. And now the second wave is the mental health aspect. And we are getting hit hard with it. Everyone has been affected by it. Like you were saying, people were facing isolation. They were losing loved ones. They were facing job layoffs, learning to navigate school online, taking care of children at home, having to be, super parents. So everyone was affected on such a different level from this pandemic. And I would say that the magnitude of mental health has just skyrocketed, especially from the pandemic.
Yeah. Yeah. There's so many stressors. I mean, like you said, all those things that you mentioned, plus just people that used to go out and do things are now stuck at home, and that messes with your mind, just, isolation and stuff. How did that change what you did? Was it more patients that you were seeing, or did people present in a different way? I mean, what changed because of that, do you think?
It was pretty interesting at first. So when we were really hitting the height of the pandemic, when everything was, pretty serious, if you will, on the news headlines, and everyone was like, do not leave your house. When the streets were empty as a provider, and it was weird to be going to a grocery store, and people took it very seriously.
Yeah.
My unit was empty for probably a month or so. I'm like, this is strange. What? I think people were afraid. People were afraid to come out because they were afraid of getting help. Just like you probably saw in your specialties, people did not want to seek help because they were more afraid of contracting the virus than seeking out medical attention. So that was kind of how it started out. Nobody was coming in. And then we started to get hit hard. And over the last few months, it has been full to the brim, every single night, nonstop. And I feel like the severity of what patients are presenting with has been building with complexity. Most of the patients that I was able to care for were never straightforward. It wasn't just them coming in with anxiety. It was, I have a substance use disorder. Also patients suffering from schizophrenia and homelessness and 10 comorbidities, stacked on stacked on stacked.
Right.
So everything is just kind of amplifying.
So. I remember, so my inpatient, my psych rotation was like 4 weeks of straight inpatient psych. And I remember that was like mind blowing to me, because from not having any psych background and just listening to stuff in class, of course, I think probably anyone that's not been in psych or experienced it firsthand, you're kind of like, yeah, whatever. But then I remember seeing like full blown schizophrenia, like watching people actively like look at the ceiling and talk to, things that aren't there. And that's like one version of psych, right? That's like the hardcore, what I think probably most people are like, you have a mental health issue. I think the one thing I've noticed out of the pandemic, and I'm curious what you think, is just when I say basic things, which can be complex though, is just the depression, anxiety, or more and more people that maybe because they're stuck at home and doing things are grappling with this. I don't feel right. Something seems off, but I don't know what to do with it. So what is, I guess, your guys' approach during that kind of stuff where it's like the average, the average Joe on the street that thinks nothing's wrong with them just doesn't feel good. How do you get them to understand that, like you said, I agree with you that probably everyone has some level of, I get anxiety, depression all the time, maybe not to the point where I need to go talk to someone, but how do you get people like that to come out of their shell, and what's, I guess, the key?
Oh, wow. This is a big question.
My dog is
a nice loaded question.
I know. I'm sorry.
No, it's good. It's good. I think the first thing is just checking in with people, being being able to talk with them on a personal level and establishing that trust, because I think, like you were saying, nobody thinks that there is anything wrong with them ever. We're all hardcore machines. We're productive. Point A to point Z. That's it. But then once you actually can confront someone with trust, and you establish that connection, you know, it doesn't even have to be about, it can be about your cat. Like if someone started talking to me about cats, I could go on for days, or talking about CrossFit, something that I'm passionate about, whatever it is, you know, that person's going to want to open up, and then you're going to end up talking about layers that you never intended to get into, you know, and then when you get to those points, you're going to discover pieces that are so much deeper. And then I think that is also going to allow the other person to really reflect and, oh, this maybe is a little bit out of character for me. Oh, not leaving my house for, 10 days straight. That's not normal. Or, oh, I have been having like 12 alcoholic beverages a day. Like, you don't do that too. I think just being able to connect with someone and maybe see what someone else is going through, and then, comparing that to yourself in a healthy way, because there's a whole other topic we can get into about comparing ourselves. That is going to allow for a lot of self-reflection, and then, maybe allowing them to feel comfortable sharing, and then seeing that maybe they need a little bit more support in certain areas of their lives. So
for a loaded question, that's a good answer. And I think a good tool for any new PA out there, that the fact of finding something to connect with your patients, in medicine, obviously we're not, when a patient comes in, I'm not going to lie, after heart surgery that's having psych issues, I try to not do a lot with it because of the situation of they just had a massive surgery and whatever. But no matter what specialty you're in, the fact that getting on a personal level sometimes opens people up to talk, even if it's just about, regular medical problems like their diabetes or whatever. I'm sure it's more complicated to earn trust in us, in psych, to get someone to actually open up. So I think it's important for new grads to realize sometimes their H&P, it isn't always about, what's your, medications, what's this, but actually trying to find out what kind of person, that is, to connect. So that's awesome.
100%. Finding out what moves a person, what drives them, what are they passionate about? Why did they wake up in the morning? Why did they get out of bed today? Is it because they look forward to their morning cup of coffee? Mm-hmm. Did they look forward to the sunrise? Did they have to feed their dog? Do they have a job? Yeah. There's so much more to understand about a person and to see what motivates them. And it can really cause a ripple effect and allow you to further that discussion. So
yeah, I like that you pointed out, like, to connect with them on something not even medical or psych related, but just, talking about cats or talking about dogs or talking about something, because it does kind of break down some barriers. You find some common ground, but you have the added disadvantage of, like Garner said, some of your patients, I'm guessing, have been asked a lot of questions about their psych history, and have you ever been in the hospital before, and have you ever tried to harm yourself and things. And sometimes they get paranoid because the last time they had this conversation, they got put in a hospital or something like that, and they're resistant. At least that was my limited experience. Mm-hmm. Do you deal with that quite a bit, of people that are kind of apprehensive at any medical person asking questions?
I do. Some case, an individual actually comes to mind. It was actually one of my most recent cases before I finished up in psychiatry. There was a patient, and this is very common. There is a lot of mistreatment that goes on in psychiatric facilities, if you could imagine, which is really disheartening, because these are the patients that are, don't get me wrong, every patient is vulnerable, but these patients are very vulnerable. They've been through a lot of trauma, a lot of terrible experiences, and they are looking for help. This patient had been terribly wronged in a psychiatric facility and was scarred. Came to me, were escorted in to get help, and so resistant. It's like, I don't want to be here. I don't trust anyone. Last time I was in a facility, I had been abused, just like so many terrible things. And so, that's a very common thing. And I think that that's going to happen in every single specialty. There is going to be a patient who has been wronged by a medical professional or someone working in the hospital, and we're the ones who are there supposed to be able to trust. You know, they're supposed to be able to come to us and know that everything is going to be all right. At least that's our job, you know, to protect, to heal, to look out, things like that. And so rather than jumping in and saying, you know, it's going to be okay, you can trust me. How many people say that? Everyone's going to say that. Show them, don't tell them, you know, do what you can to establish that trust. Ask them about themselves, you know? And so I asked the patient, you know, what's your favorite food? What do you like to do? Found out this patient's, you know, favorite candy. I went and found it in the hospital and brought it to them and just sat there in a room. What do you want to do with your life? You know, what motivates you? Found out this patient wanted to go into healthcare. I'm like, this is why you're going to be great in healthcare, so that you can treat people the way that you deserve to be treated. You know, being able to connect with them, just like you were saying. You know, I think that we're so focused on getting those answers out, you know, so we can type up our note or so we can get the data, order that test. Sometimes it's not about that. Because if our patient's not willing to open up and talk to us, we get nowhere. And sometimes if they don't open up to us, we're going to get the wrong diagnosis and order the wrong tests.
Mm-hmm. That's right.
I do feel like sometimes we get into that mode, you know, the medical model that both, you know, doctors and PAs are taught in is diagnose, treat, diagnose, treat, diagnose, treat. And we can get into the differences of NPs and PAs all day. It's a whole nother podcast. But sometimes I do notice that our nurse practitioner colleagues who are more taught in the holistic model, sometimes I feel like do a better job at, you know, treating the whole situation, not so much focusing on what's the diagnosis so I can treat you right away, but actually spending some time and, you know, getting to know the person a little bit more. What can we do to treat their social health, you know, or what's going on at home, all these things that sometimes I feel like providers, everyone is guilty of it, just want to jump to, you know, oh, they have depression. Here's, you know, an SSRI item, we'll go on with our day or whatever. So
yeah, 100%. And, you know, don't get me wrong. I know that there are people that will be listening to this podcast be like, but time, I have time. We got to go. I understand. Like we all know time is limited. We don't have 100 hours a day to chart. Like we have families to go home to. We have things we got to do. We have all signed up for way too many things we said we would do. Like, I get it. But, you know, sometimes these things are very important. You know, sometimes those extra 5 minutes could save a patient's life. Just like you were saying, like addressing someone's social determinants of health within the situation is going to give you an entire different treatment plan that is really going to impact this patient's life and how they are going to get better. So it's worth it.
I'm going to like, from the like next 100 people, hopefully forever, but I'm going to like spend more than 5 seconds looking at social history from now on, just from this podcast alone, because I'm guilty of it, especially in cardiac surgery. Do you smoke? Do you drink? And I move on with my day about, you know, and I don't dive into it all that much, but I think it's something that's overlooked by a lot of people that aren't necessarily in psych or another specialty where it's should be focused on so much more. So
I think also too, there's a lot of social issues that can be going on that are, you know, related. Maybe not, they're not in the hospital to get heart surgery because of this situation, but I found just in, you know, questioning patients like, so what's going on? Like, you seem really fired up about this. Like, what's bothering you? And it turns out that they're worried about finances, or they're worried about who's going to take care of the farm while they're in the hospital. Or in one case, it was the husband and wife were fighting, and I just couldn't, something didn't seem right. And the longer I talked to him, I was like, I wonder if the wife is like in danger, you know? And so, you know, just asked her to come out in the hallway, and I was like, are you okay? And she's like, no, like if he goes home, he's going to kill me. And I was like, oh my goodness. Okay. Very not exactly what I expected to hear from you. Let's get social work and let's get some people involved. And I mean, just asking questions is huge. And of course, it does go down the rabbit hole sometimes of hearing the life story, which is great. But like you said, we've got limited time. And so you have to be able to tease out some of the important stuff, which takes practice. How long did it take you to feel comfortable with diagnosing and treating psychiatric issues? Because in my personal opinion, I don't know that we covered them that much. It was kind of like, here's depression, here's anxiety, here's schizophrenia. And it's very black and white, you know, vignettes that you get in school. Whereas when you meet people, it's so complex. I don't know if I still could get it now, but how long did that take you to get up to speed?
Yeah, I would 100% agree. I think our education as far as behavioral health is terrible. I think not just for PAs, across the entire healthcare, professional world, I think that they dedicate this much time to psych related issues, and it's pretty disheartening. Like you were saying, psych is everywhere. When people say I don't want to work in psych, I'm like, probably shouldn't go into medicine then, because psych is everywhere. Maybe you don't want to prescribe SSRIs, antipsychotics, anti-anxiety meds, but you're going to be working with psych every single day. You walk into your clinic, your hospital, your telemedicine appointment. Psych is everywhere. Psych is when you're talking to your family. Psych is everywhere, and people don't realize that. So I think that they really need to do a better job at education. I'm not saying they need to do 100 lectures and talk about, pull out the DSM criteria. People don't need to know that. They don't. People need real life application of how to work through, psychiatric conditions that come up every day. How to talk through situations when life is difficult, stressful, when someone's experiencing anxiety, things like that, which we can dive into in a little bit in the podcast. But that's what they need to teach at school. I don't care about the psychopharmacology. That's not useful for people who are working in, rural medicine and have nothing to do with psych if they're working, under a microscope, things like that. Anyway, I feel like I still struggle with being able to differentiate the different diagnoses. But what I saw was pretty repetitive over and over. Like I said, I saw a lot of overlap between conditions. And the pharmacology kind of just came. Since I worked at night, I prescribed pretty much the same things over and over, unless it was a medical condition coming up. Then that is the part that really kept me on my toes. Or if, a patient was more acute, I'd have to augment certain medications here and there. I would say a few months. It took me a few months, but I did have a background in behavioral health. I worked as a behavioral health specialist, which is kind of like a fancy title for a psych tech. So I did that for a couple of years prior to PA school. And then I also did research during my undergrad working with suicidal adolescents. So I've kind of been exposed to behavioral health models and conditions for quite some time, which kind of really exposed me with how to converse with people who are in crises, which I think it's very scary for people who have never foreseen that. If someone's trying to jump off the side of the building, people are going to panic. Just like, for me, when I'm transitioning into this new role and someone's coding on the side, that's going to be very uncomfortable for me. Like for you guys, that's probably like, this is no problem. I got this. For me, I'm going to be like, okay, like I need help. That's, that is very uncomfortable for people to walk through when someone is saying, I want to kill myself. I don't want to live anymore, and that's what we need to work on as a society is helping people lean into that discomfort and knowing how to navigate through those processes, because that takes time.
Yeah. So this may be just to go off what you were talking about in terms of as a society, what we need to do, how can we be better about this stuff? So like, I know you do advocacy and stuff like that. So in terms of like stigmas of, mental health, what I see the most is, for example, older male patients are the ones, maybe they're in the hospital or they're going to they need surgery, whatever it is. And I literally have to have conversations about, hey, between you and me, I ordered this anxiety medication and you're pretty worked up. And if I was you, to get some rest tonight, I think this would be a smart thing to do. Or while you're home for the week before surgery, things like that. And it's like crazy how much you either see I would never do that, or because no one's in the room, it's what, you're right, but can like, just don't talk to my wife about it. Like she's stressing me out, things like that. And that's part of that stigma. So I guess part of you talk about advocacy, things like that. What are you doing, or what are things out there that we could be doing to help with that?
Oh, this is my favorite question. And I'm so glad that you brought it up, because yes, absolutely. Like no one wants to hear, hey, you need some therapy, or like, you should probably take some meds, and I think that's all because society has ruined the way that we look to these resources and tools. Like it's a bad thing, Just like, if you break your arm, you're not like, oh, like you should probably get a cast on that. Nobody says these things. Oh, that's
unless you're a wuss.
Yeah. Oh, kind of a little weakling if you have to get a cast on that fractured arm.
Yeah.
And this is all society's fault. This is what has happened over the years, and males especially. Like males, if they have to go near therapy, like, God, the world is ending, We don't go there. We don't talk about that.
Right.
So, I think it's really important to just start having these discussions that it's not a matter of if someone is going to need help with their mental health, it's when. It could be small, it could be large, it could be ongoing, it could be for a day. It doesn't matter. Everyone's going to go through it at some point in their life. Maybe people already have. It might happen once. It might happen for 10, 20, maybe the rest of their life. It might be a chronic condition, So I think, number one, just put that out there. Number two, we need to start treating mental health as if it is physical health, because it is. They are so closely intertwined. When your mental health is suffering, your physical health is going to suffer. If your physical health is suffering, that is also going to take a toll on your mental health. Yeah. I'm sure you guys see this all the time. Those who have undergone a huge surgery or procedure afterwards, people are down in the dumps. They feel like crap, and their mental health is terrible. They have had things taken away from them. They're not going to go out and run 10 miles. Like, they are starting from ground zero, and that is... it's really hard to cope with. So I think just normalizing it, like, and educating our patients or our family members, our friends, hey, you take this ibuprofen when you're in pain, there is no difference. You take these medications if you need help. We are helping the neurotransmitters in your brain. This isn't a matter of you're weak or, you're being a baby right now. This is you resetting your physical health, helping you get back to being your best version of yourself possible. So I think having those two really important conversations is kind of where we start, and how we can really go about doing our parts as providers, or, you don't have to work in healthcare to be a mental health advocate. I think people think they have to work in psychiatry. They have to be some type of mental health professional to take a stance and help people. But the truth is, like, it's even better for people who don't work in the medical health setting, because then it doesn't look like you're being forced to say these things.
Yeah.
Yeah.
So I'd say step number one is getting curious, meaning we go there in conversations, checking in with people and getting uncomfortable. Like I said, nobody wants to say the S word, suicide. Yeah. People say suicide and they're like, oh my gosh, what did you just say? Like, I'm uncomfortable. Suicide is just like a normal word, and people turn white in the face. Yeah. They're like, don't say that.
Yeah, they say don't say that, or don't give them ideas, as though they
haven't already thought about it.
Yeah, right.
Yeah, don't give them ideas. Like, if someone is really wanting to end their life, they have already done it, or they're going to do it. Saying it is not going to make it any worse. Okay. So, promoting these discussions surrounding mental health, surrounding suicide awareness, just having them. And it's going to feel really uncomfortable to every single person, just like things that you did in your career that you had no idea what you were doing. Yeah. That was uncomfortable.
Right. That's medicine. Tying a suture is uncomfortable. It's awkward the first couple of times you do it. And you're like, oh my gosh, I've got two left hands. Same with this conversation. Is the first handful of times you do it, it's going to feel weird, but then pretty soon it gets to be within your comfort zone. And now, this is okay. I can do this.
Absolutely. You might feel like an idiot at first. You might feel super awkward. But honestly, it's awkward when you make it awkward. Just like when you had to take sexual histories when you were a PA student and you're like, I don't want to do this. You know what? Your patients are the ones, they're going to feel awkward when you feel awkward. Like, no sugarcoating, ask the questions, be straightforward. And the more that you practice, the better it's going to be for you and the person,
That's good advice. Yeah, that's great.
I'd say that's step one. Step two, keep promoting those discussions, wherever you are, whenever it comes up. It's okay to have that. Step three, educate. And when I say educate yourself. I still, I'm working on it every single day. There are so many resources out there for people when they need help. There's crisis lines, text lines, warm lines, So many resources. So have those protocols near you. Have them in your pocket, screenshotted. I have a little post on my page. You can take a screenshot, have it pulled up. It has any kind of resource you would imagine like possible, and have that. You don't know when you're going to be on the side of the road and someone's going to be trying to jump off a building, or maybe you've had a really horrible day at work, and maybe your colleague's going to come up to you and be like, hey, listen, I'm done here. Like, thanks for being a good friend. Like, you just don't know. And you don't want to be caught off guard. You want to be ready. You want to know how to go about the situation, and having those resources, being able to, talk someone through what to do and where you can get help, where you can send people. You don't want to be that person that's filled with regret after being like, I wish I would have just known what to say. I know it's scary. It's terrifying having to talk to someone about ending their life. You don't want to, but you can save lives by educating yourself so you can educate others. You really can.
That is awesome.
I think this has encouraged me to start a hotline, and it'll just be Chris's phone number. We'll just add it to the bottom.
Oh my gosh.
I am a talker. I am always in patients' room. I'm like, really, tell me about the, and like there's it's not everyone does love that.
I love it until I need his help with things. I'm like, hurry up.
Yeah. What is he doing in there? But I get myself into a hole sometimes, because sometimes the surgeons that we work for are like, don't get involved in that. And it's like, but it seemed like it was something I needed to get involved in. So yeah, if you made a hotline with my number, I just wouldn't come to work. I'd just answer the phone.
Stuck at home.
And you know what? I would like it, but I don't know that I'm qualified for it. So I'm going to educate myself. So yeah, right.
Hey, I'm here for backup if you want to start it with me.
There you go.
Excellent.
That way, I'm sure people are going to start punching me in the face at my new job. I'm like, get out of here. I did not hire you to start talking 15 hours a day to patients.
Going into, I'm not going to lie, two things I did not want to do: psych and burn trauma. Those are like two things coming out of school that I was like, nope, you can cross those off the list. So props to you for tackling it, but I'm sure that of any specialty has its psych, but burn patients, that is a roller coaster altogether, especially, the whole psych side of it. So I'm sure it'll be a nice, tool to have in your pocket to have had experience dealing with those types of things. So
I'm glad we have people like you out there who are willing to do that, because I would be like, oh man, like that's intense. All right. So for students that are out there right now, how would you describe a typical day or even a week if your schedule changes a lot? Like when do you go into work? What do you do when you get to work? What do you do when you're at work? When's the day over? Stuff like that.
Okay. So my position is pretty unique. I feel like most psychiatric positions are not going to be like this. So I can kind of cover what I do and what I think the typical norm for a psychiatric PA would be like as well.
Perfect. Love it.
Kind of see both sides.
Okay.
So I was working the night shift. I would head in at about 7 p.m., get reports, see what's going on, checking in on the patients that I have, which was usually none. And then they would all come flooding in the middle of the night. They all came in at night. I would get several admits throughout the night. Patients would come in. I would do a full psychiatric assessment. So that is, I would say, where the bulk of my time went. My interviews would take anywhere from 20 minutes. That was pretty light.
That's pretty quick. Yeah.
Usually they're about an hour. Mm-hmm. So anywhere from 20 minutes to an hour, get them settled. And like I said, there was no other medical personnel on my unit. So I also would, enter their medications if they brought any, and then, order new medications, put in all their orders, and then actually administer their medications so that they could sleep. So, we're doing the whole assessment, checking in, doing orders, getting night medications, administering them, get them all settled. That kind of takes a few hours in itself for one patient. And then charting, which is not my favorite part of being a PA.
It's no one's favorite part, that's for sure.
It is not. Charting took me forever. My HPIs were like 18 encyclopedias long. So I'm being dramatic. But yeah, very long notes. Working in psych, the HPIs are just ginormous. It's just how they are. Charts on the patients, and then just keep an eye on them throughout the night. A lot of them, they have history of trauma. A lot of them have nightmares. A A lot of them are, withdrawing from substances, so they're not sleeping too well. So have to order more medications, maybe talk with them throughout the night, reevaluate, reassess more vital signs before I give more medications, and then just kind of go from there. And then things kind of wind down around 4 a.m. and then just kind of coast from 4 to 7 a.m., just kind of keeping tabs on them, making sure they're doing well. And then that's kind of how the night goes. And then hope no medical emergencies happen in between.
Yeah. And that was a 12-hour shift. And how many of those did you work in a month?
So I did 3 12s. That was my baseline. I also, I worked a lot. It was not my favorite part of that position. So we were pretty slim on PAs. They're working on getting more, but I worked 3 12s. So I did Wednesday, Thursday, Friday nights. I typically would do a call shift on Saturday day and then flip into a day on Sunday day. And then I would have Monday day off, Tuesday day, back Wednesday night. So I was working well over 60-hour work weeks for about a year and a half straight. I felt like trash all the time. And I'm just saying for everyone out there, it's like, I'm not going to psych. This is not normal for psychiatric PAs.
Yeah.
This is not the normal. Most psychiatric PAs, a lot of them will work 4-10. Some will do Monday through Friday, the classic 8 to 5. Most people do outpatient. So they're seeing, 20 patients a day, sometimes less, sometimes more, anywhere from 15 to 30 plus minute appointments, depending on if it's a medication refill or if it's a new patient eval. It just kind of depends, but mostly just doing prescription refills or new patient visits. And that's kind of how it goes for the outpatient world. Lots and lots of medications, lots of continuation of care. I worked in that crisis unit, so mine was just, I see these patients for 12 hours, and then I have a whole new spectrum for patients the next day. So I did not prescribe any daily medications as needed. They were all just acute medications. Whereas if you work in outpatient, you're going to be following these medications. These are going to be long-term medications for up to, years, maybe indefinitely, things like that. So maybe have to monitor labs, things like that. Whereas I didn't do anything like that. So
is there any therapy stuff in outpatient psych, or is it mostly prescribing?
It is mostly prescribing, so it depends on the state. And as of right now, so I worked in Utah, PAs cannot do therapy in Utah. However, this is kind of exciting. I am the vice president for the Utah Academy PA Psychiatry subgroup committee. We just passed a bill. We are now part of the Utah Mental Health Practice Act, and we will now be granted assuming the governor signs the bill, we will soon be allowed to do therapy as PAs.
Congratulations.
Thank you.
That's
we will
awesome.
now be able to do therapy and be independent mental health practitioners. But there is quite an extensive, rigorous checklist to get through that takes years and years and years to get through. But it makes sense. And a lot of people are there's a mixed response. A lot of people are discouraged and like, okay, well, why would I even want to do this? But the whole point of this bill initiative is to really complement what PAs are doing in mental health. And, if you're happy with where you're at, then nothing's going to change. You can still show up, you can work in mental health, you can do what you want to do. If you want more, here is the door, here is, the gateway to really go and advance as a mental health practitioner. And it's a way in, we have a way in, and that is a huge milestone for us as PAs.
That's great.
Yeah, it's a step in the right direction for sure. And maybe unless you want to ask something else, I say maybe it's to transition to, we get asked a lot about the future of PAs in general. And in terms of psych, obviously in Utah, and obviously I'm not going to lie, I'm not super familiar with like therapy laws in the state that we're in, but I'm sure they're similar across the country. For the future of new grads coming out, we hear a lot of worries about flooding the market. There's not going to be jobs. It sounds like, at least, that's a promising thing, that there's doors opening, for PAs to do more in psych. What do you see specific to psychiatry, the future of PAs kind of looks like?
I will say, I don't think there was ever a decrease in demand for PA positions regarding psych. Like I said, everyone has underlying mental health. The demand for mental health providers is huge. There is such a need. The average wait time to see a psychiatrist is over 6 months in most states. It's huge.
That's terrible.
There's just not enough psychiatrists out there. And we have nurse practitioners, thank goodness, and there are PAs, but we need more mental health providers. We do. So there are always mental health jobs out there. So I would say the prospects of anyone wanting to go into mental health are really, really great. Any state, and PAs for the most part cannot do therapy. Nurse practitioners can, and psychiatrists can. But with these bills kind of advancing, I see the future. There will be therapy for PAs, at least in Utah. That's where we're starting out.
Awesome.
So
that's great.
That's awesome. Was the bill, was your part of the bigger bill that opened up the practice? What was it, 5,000 hours or 10,000 hours of supervised practice?
So the Modernization Act,
yes.
That one that you, yes, I was also took part in that bill. So that's also really exciting for Utah. So we are hoping that is going to have a huge ripple effect. So I can see why a lot of people are panicking, because they're like, oh my God, I went to school. I did not go to school to be an independent provider. No, hold the brakes. But here is the thing. We are never going to be working outside of our scope of practice as PAs. We're not going to do that. We're not going to go perform surgery alone. We are not going to do these things, and I think I can understand why other, health professionals are concerned when they see the word independent practice. If I wasn't a PA and I wasn't educated on what our scope of practice was, I'd be like, I'm sorry, you want them to do what with me? No, absolutely not. They're not physicians. But that's the thing. We're not stepping outside of our bounds. We're not doing that. And for new grads, we are not throwing you out to the wolves. There is going to be a contract in place. You are going to have to be required to have supervision as a new grad, no matter what, and the thing is, this whole bill creates this initiative for, we like to call it in Utah, interdependence. We don't want independence, but we still want that whole interdependence collaboration, if that makes sense.
Yeah,
we're
totally.
We're not looking to be alone. We're not people alone on an island isolated for everyone. This allows us to collaborate with multiple physicians, multiple members of the healthcare field. We don't have to be solely tied to one physician. We can go to any physician and get feedback and collaborate and become better. So this really allows us to advance and grow as providers. And I think that if we took the time to explain what is really happening within this bill, people would feel more at ease and see that this is actually going to help our communities, help our patients, help our colleagues out too, help our physicians out. They're not going to have to be signing off on charts for patients that they've never even seen before. Like, take me, for example. I never saw my supervising doc. I never worked with him once. I never, ever saw him except for on, monthly staff meetings. And he was signing off on every single chart. That's not fair to him. If something were to go wrong, that's not fair to him to take the blame for something if I were to have done something. We're really helping protect them and also protect our patients. And it makes us be more responsible for our actions. So
that's great. And I think it will have a ripple effect. I think Colorado already introduced a bill that was very similar. I think Colorado. there's a
Kansas
meeting. Kansas
is doing
well.
one.
Yeah. So, and I'll be honest with you, I don't know exactly what that looks like in day-to-day practice. In our specialty, obviously, we're not going to be doing heart surgery on our own, but what does it look like, out in the community and things like that. So I'm excited. Thank you for all your work that you did on it. I'm sure it was not an easy thing. Was Utah the first state to do that? I think they are, right?
I believe there are a few other states. There is 2, I believe, that have optimal team practice as well. We might be the first as far as the whole mental health initiative, though.
Cool. That's great. Well, thank you so much for putting your time in, and that's exciting. So that's good for the future, for sure.
Thank you so much. It was great to be part of. But yeah, whoever is listening, like, things are good. I know it sounds scary, but you know what? Our profession is meant to grow, and we have to grow. You know, physicians are growing, nurse practitioners are growing. We have to grow with them because we are collectively a healthcare unit, and our patients are only going to be benefited when we are strengthened as a whole. So we have to. That's
great. Cool. Well, thank you so much. I mentioned at the beginning that you're active on Instagram. Where can people find you if they want to find more information about you and kind of look at your history in psych and then watch your current journey in burn and reconstructive surgery?
Yes. So you can find me at sparkles_and_scalpels_. It's kind of a joke. People call me Sparkles. I'm pretty active on there. I love to do Zoom events for pre-PAs, a ton of that. My DMs are always open. I'm now active on Clubhouse, doing a lot of that. So if you two are not on Clubhouse, get in on it.
Yeah, so I asked my daughter, I saw your thing about Clubhouse, and somebody did invite us to Clubhouse, but I was like, I don't really know what this is all about. And I asked her, and she was too busy looking at TikTok, so she doesn't really know. But tell us, what do you do on Clubhouse? Is it like live streaming?
Yes, it's kind of fun. It's kind of like this. So essentially, it is like a live podcast feel. You just can't see people, so it's audio. And it's a great way to connect with people. So there are rooms happening. You can start a room. You can enter a room. Someone can essentially like ping you, and you'll get an alert to be entered into the room. And there will just be different types of various topics happening. It's been a really great way to connect with our pre-PA community. There are a lot of people engaged in Clubhouse who you aren't seeing on Instagram. I feel like the vibe is more mature and educational, which is nice because it's nice to really, get more of that informational feel rather than like, Instagram can be, or TikTok can be kind of, overwhelming or kind of silly at times. And Clubhouse is just, it feels very supportive. I really, really like it.
Cool.
And I've learned a ton from it. So I hope to see you guys on there.
My TikTok is very serious.
Yeah, yours is just it's all business.
I don't have any social media besides what we do, so I don't even know how to use a TikTok.
Yeah.
I can't. I have forbidden myself. You are not getting on TikTok, Ariana. You waste so much time on social media already.
I know.
Well, of all the things, Chris has got a few years on me, so it blows my mind when he's like, "You want to see my TikTok?" And I'm like, "You have what?" Like, I don't even know how to use the thing.
I got it to spy on my kids because I just want to make sure they weren't up to no good. And then I ended up being like, I was like, hey, and so my name is like not my name, like.
Or it's one way to get your kids off TikTok is start being all their friends.
My dad is lurking on TikTok, but then I realized I was like, oh, this is kind of fun. So I just like made videos to make my kids laugh, and then I'm like, hey Garner, you want to see my TikTok?
I love it. Hey, that's smart.
It's
2 in 1, being able to spy and then also connect.
That's right. It keeps me young. It's all good. So we'll have to check out Clubhouse for sure. That sounds fun. So
yes.
Well, thank you so much for your time. Thank you. We had to reschedule this a couple times, so thank you for making this work in the midst of your move and everything. What's next for you? Tell me about what prompted your change to burn. What's going on?
Yeah. So my handle, as I was saying, kind of a joke. I've debated on changing it, but I feel like the Instagram community just knows me as Sparkles now, so I'm too far in.
You're committed. Nothing you can do about it.
I had, so I've always had this huge passion for mental health, as I have rambled on and on. Bless you guys for listening to me and my mental health, like forever. It'll be engraved in my stone when I die.
That's great.
But, I had a plastic surgery rotation as a student, and I absolutely fell in love. It was reconstructive plastics. I just loved it so much, and that's where the name Scalpels came from, because I knew that's where I was going to end up. I knew it, and so I was manifesting it with my handle. I'm like, one day we're going to get there. To me, I wanted to be in a role that encompassed a lot of, like you were saying, a lot of mental health. And to me, reconstructive plastic surgery has just enough mental health to be able to work with such a vulnerable population who essentially has had a very intimate or special piece of their life that has been stripped away from them. And we as providers are able to, work closely with them, learn about them, like I said, learn about their passions, their drives, who they are, and to be able to create something so special and unique that no one else has, and be able to give maybe even the slightest piece back to them to restore who they once were. That's where it's at for me, and to be able to restore a little bit of that confidence. So that's why I wanted to do reconstructive surgery, and then also, not be able to just treat them from a physical aspect, but also address their mental health. So that's why I'm there.
Cool. Awesome. Well, good luck to you.
Thank you.
Like you said, we'll have to circle back and do another day in the life once you could tell us about what that's like, because burn and reconstructive is it's a big specialty. So that's impressive.
It is.
Cool.
It's going to be very challenging for me. So not a lot of people know this. So now I'm like telling it to the world. I am kind of woozy with blood, surprisingly. Like I've had to like decondition myself to not get lightheaded, and I can do it. Like when I was on my rotation, it took time for me. So that's what I'm saying with the whole suicide word. You guys can do this.
Yeah.
Just
Right.
like I'm gonna have to do this. Like it's something I'm so passionate about and I love, but like that is something that is not easy for me. Like when I see like really intense things like that, I start seeing like the gateway to heaven. I'm like, oh, okay, get it together.
That's how Garner is too. He passes out every time he sees blood. Every time. Doesn't. I mean, it's like 8:05 and he's on.
I just try to avoid falling into the patient's chest.
Yeah.
Fall away.
We fall backwards. Yeah.
Just, if you're gonna pass out, just don't desterilize the field.
Back. Just go right to the head, clunk.
Honestly, the very first case I ever watched was a heart surgery. I had never been in surgery before, so I started with a mitral valve replacement, and the smell of the cautery was what killed me. And I was like dry heaving, and like I thought I was going to throw up. I was like, this is terrible. We have people pass out all the time in the OR, but like you said, you just have to kind of get through it. And now it doesn't bother me at all. I mean, it's kind of gross, but you can be cauterizing and there's smoke everywhere and nobody's suctioning the smoke, and it doesn't bother me a bit. Like I'm over it apparently, or I'm really twisted. I don't know. Could be either way, but
Maybe a mix of the two.
yeah, it's a mix. So you'll get over it.
Cool.
It'll be awesome. So
Thank you so much.
That's cool. Well, good. Well, thank you so much for your time. Good luck to you.
Thanks.
I will link your Instagram below. And just thank you so much. Good luck to you in the future. And I'm sure we will talk to you again soon.
Sounds great. Thank you guys.
Awesome.
Nice to finally meet you in person, and I hope to talk to you guys soon.
Yeah.
All right. Take care.
All right.
Thank
See ya.
you.
Bye.
Have a great night. See you.